Good morning, ladies and gentlemen. I'm Chen-Chi from National Taiwan University. 我是台湾大学的吴正吉。那 the title of my talk today is Precision Medicine in Childhood Hearing Impairment, from Diagnostics, Prognostics to Therapeutics. So in my talk today, I will start from the diagnostic. I will introduce the genetic examinations we perform in our hospital. And then I'm going to move on to the prognostics. I will introduce about how we use genetic information to make clinical decisions. And then I will conclude my talk by talking about the therapeutics and the unmet clinical needs. So we know that hearing impairment is a common disorder in children. It may occur in about 2 per 100 children. And we know that genetic factors are very important in children with hearing loss. It may account for more than 2/3 of the cases. And to date, more than 200 genes have been identified to be related to childhood deafness. So for a patient with moderate to severe hearing loss, usually hearing aid fitting is the first choice. But for patient with a profound hearing loss, cochlear implantation is usually necessary. So over the past 2 decades, we have performed a large scale genetic study in Taiwan, which have already recruited more than 7,000 patients. And with comprehensive genetic studies, we found that the diagnosis can be confirmed in about 80% of a patient with profound hearing loss, including 50% with non-syndromic hearing loss, the pinkish area, such as GJB2 mutation or SLC transient mutation. 10% is a syndromic hearing loss, such as Waardenburg syndrome or Chen-Chi syndrome. 10% is related to acquired causes, such as congenital CNV infection, and 10% is inner ear malformation, such as cochlear nerve deficiency. So here you can see the current genetic testing protocol for hearing impairment at NTUH. We have commercialized an NGS-based genetic diagnostic panel, and we offer this service to every patient with affordable price. And for those without diagnosis, we usually will proceed to perform whole genome or whole exome sequencing. And we are right now also doing the long-read third generation sequencing. And with this advanced sequencing, we can additionally achieve diagnosis in about 1/3 of the multiplex families. So here you can see that NGS can help achieve a genetic diagnosis in the unsolved families. By doing NGS, we confirm that the deafness in this multiplex family is actually caused by a rare POU4F3 mutation. And because of our NGS panel also include some syndromic hearing loss genes, so sometimes this panel enables us to achieve earlier diagnosis in patients with syndromic hearing loss. For example, in this family, originally we thought that this family was non-syndromic, but we performed NGS and we identified a GATA3 mutation, which is linked to the hypoparathyroidism, deafness, and the renal syndrome. So after we confirmed the genetic diagnosis, we rechecked the clinical features of the affected members again, and we found that there are some members, they already show some symptoms with renal problems. So this is an important information for these families because the affected members can have a very close up renal or endocrine follow-up before the manifestation of the clinical features. So there are limitations for NGS-based diagnostics. For example, in patients with severe to profound hearing loss, the diagnostic the diagnostic yield of NGS is about 60%. But for patients with mild to moderate hearing loss, the diagnostic yield of NGS is about 40%. So there are still many cases remain undiagnosed. So for such cases, if there are multiple affected members, usually we will perform more comprehensive genetic studies such as whole exome or whole genome sequencing. For example, in this multiplex family, we found that deafness in this family actually was caused by a DFNA5 mutation. And there is another gene that is also often missed by the conventional short-read NGS sequencing, which is the STRG gene. The mutation in the STRG gene are associated with mild to moderate hearing loss, and the structure of this gene is very complex because there is a pseudo gene nearby. And the most mutation of this STRC gene are large deletions or large insertions, which are very difficult to detect using the short-read NGS sequencing. So we are currently using the third generation long-read sequencing using both the PacBio platform and the NanoPower platform, try to address this gene, which we believe will further increase the diagnostic yield of our genetic diagnosis in patients with mild to moderate hearing loss. So let's move on to the second part of my talk regarding the prognostics, and I will going to talk about how genetic information can be applied to help the clinical decision making. So we know that genetic diagnosis is closely related to the clinical course. Some mutations are associated with stable or progressive hearing loss, and some genetic mutations are associated with fluctuating hearing loss. So if we know the genetic mutation, we can somehow know the clinical cause. So this information can help us predict the time of CI surgery. In our previous study, we established a prediction model for GJB2 related hearing loss. And using this model, if we know the age of the patient, the genotype of patient, and the baseline hearing level, and we can know somehow like 8 years how severe the hearing loss will be. So this information will help us predict the time of the CI surgery. And what we have done over the past years is we are trying to construct an integrated cloud database in our hospital. We try to digitalize all the audiological data, and we try to integrate the genetic information, the imaging data, the past medical history data, and the audiological data. And together we use this data to build a hearing prediction model. So in our recent studies, we also applied AI to construct a prediction model for GJB2 mutations. And we try to compare the performance of the AI model to the conventional statistical model. So our result based on more than 6,000 audiometries of 800 GJB2 patients showed that the AI-based models work quite well for GJB2 mutations. The prediction accuracy of our GJB2 prediction model is about 3 decibel right now, but we think this will become even better after in the future if we accumulate more and more patients. So the conventional statistical model is difficult to use to predict the clinical cause of some genetic mutations, such as the SLC26A1 mutation. SLC26A4 mutation are associated with enlarged vestibular aqueduct, and actually SLC26A4 mutation are very common in the Han Chinese patient. About 90% of Han Chinese EVA families actually are caused by SLC26A4 mutation. And SLC26A4 mutations are associated with fluctuating hearing loss, which make it very difficult to delineate using the conventional statistical model. Here you can see the progression of SLC26A4 related hearing loss based on more than 1,500 audiograms. You can see that both the better ear and the worse ear deteriorate gradually, but the hearing loss pattern is very, very irregular. So I think it's very difficult to use conventional statistical model to do the prediction, but AI-based prediction model might work better. So in addition to the clinical course, genetic diagnosis is also closely related to the CI outcome. So over the past years, we have performed comprehensive genetic studies in more than 500 children with CI in Taiwan. And we found that genetic mutation in most of the genes, such as GJB2, SLC26A4, and the MYO15A are related to a good CI outcome because the pathology of this gene is confined to the inner ear. But we also found there are some genetic mutations associated with poor CI outcome, probably because of the involvement of the spiral ganglion neurons. So based on these findings, we have included genetic examinations into our pre-CI candidate battery in our hospital. For every CI candidate at NTUH, we performed audiological evaluation. We perform image studies with MRI and HRCT, and we are also performing a genetic examination in every patient. So genetic diagnosis is particularly helpful in the management of auditory neuropathy, the AN. AN actually is not uncommon in childhood hearing loss. It may account for about 10% of the childhood hearing loss cases. And the etiologies of AN are highly heterogeneous. Any site of pathology ranging from the inner hair cells to the auditory cortex may lead to AN. So here you can see the etiology of pediatric AN at our hospital. You can see that actually the most common causes of pediatric AN are acquired causes such as prematurity or kernicterus. Genetic causes can be identified in about 20% of the patient, and the autosomal mutation are the predominant genetic cause. So according to the site of lesion, AN can be classified as presynaptic and postsynaptic. And usually, presynaptic is associated with a good CI outcome, whereas postsynaptic is associated with unfavorable CI outcome. So we know that for the AN patient, the site of pathology is crucial regarding to the CI outcome. So several papers, including a couple of ours, have demonstrated that a good CI outcome can be found in AN patient with autosomal mutation because the pathology is confined to the synapse and the nerve is intact for the function of CI. So the autosomal patient usually showed a robust ECAP response during the surgery, and usually this patient show a very good auditory and the speech performance after CI surgery, as shown by the gray lines here. They show good auditory and the speech performance after surgery. So for AN patient with autosomal mutation, early cochlear implantation is indicated. So as I will mention later, although there are some recent papers showing very good result on gene therapy for autosomal mutation, I think that for autosomal patient, early implantation should be performed at least unilaterally to ensure the good outcome. So this is another case how genetic diagnosis can help our clinical decision making. This is an 8-year-old boy with progressive hearing loss, and you can see that there is low tone residual hearing. So in this case, should we proceed to a cochlear implantation, and how to select the device? So in this patient, we performed genetic testing and found mutations in the MYO15A gene. So this gene is expressed at the stereocilia of the hair cells. So actually the nerve is intact. So in this patient, this is a good news. We know that the nerve is intact, and the CI, good CI outcome actually can be expected in this patient. So to date, we have more than 50 patients with MYO15A mutations in our Taiwanese cohort, and we found that residual low tone hearing is common in this patient, and about 70 of them will suffer from progressive hearing loss. That means that the residual low tone will begin in the future. So if a cochlear implantation is to be performed in this patient, 2 factors need to be considered. First is the hearing preservation. The second is the progression of the hearing loss, as I just mentioned earlier, the progression of hearing loss. So taken together, a thin electrode with sufficient length should be chosen for this patient. For example, if the parents ask for a Medel device, then Flex 20 might not be a good choice. Flex 20 might be good to preserve the hearing, but it may not cover the low tone frequency. If the low tone hearing is gone in the future, Flex 20 cannot cover the low tone frequency. So for this patient, the Flex 28 will be a better choice. So genetic information actually can also help the clinical decision making in single-sided deafness patient. So in our paper published several years ago, we tried to investigate the genetic underpinnings of patients with unilateral hearing loss with scale-out hearing level, unilateral hearing loss with residual hearing level, and the patient with asymmetric hearing loss. And we found that genetic cause can be identified in about 10% of these 2 groups, and about 30% of this group. So for example, in these 3-year boys with single-sided profound deafness, we found that the deafness actually is caused by EDNRB mutation, which is a Waardenburg type 2 gene. So this is an important clinical information because we know that the pathology of Waardenburg syndrome is confined to the stria vascularis. So we will know that the cochlear nerve and both the cochlear nerve and both the cochlear structure are good. So for this patient, cochlear implantation will be a good choice. Yeah, because the pathology does not the pathology does not involve the spiral ganglion neuron or nerve. So for patients with single-sided deafness, about 40% of them are related to cochlear nerve deficiency. About 10% of them are related to genetic factors. The treatment should be different for this patient. For patient with cochlear nerve deficiency, cochlear implantation might not be a good choice. But for patients with genetic etiology, cochlear implantation can be considered as the treatment. So let's move to the last part of my talk about the therapeutics and the unmet needs. So in addition to the diagnostics and the prognostics, the therapeutics using gene therapy is also evolving quickly in this field because there are some unmet clinical needs, including a patient with poor CI outcome And the patient with progressive hearing loss, for example, if we have a chance to do intervention here, then we might have a chance to stop the natural cause of the patient. So in my personal opinion, I think that there are 4 potential entry points of gene therapy in this field. The first one is auto-related hearing loss. The second one is syndromic hearing loss with concurrent blindness and deafness. The third one is SLC 26A4 related hearing loss. And the fourth one is the genetic etiology related to poor CA outcome, such as PJVK mutation, as I just mentioned. And of these 4 potential entry points, the auto-related hearing loss will be the first one to be translated into clinical practice. So this is because in 2019, there are 2 back-to-back papers reporting good response of gene therapy in auto-mutant mice. You can see that after gene therapy, the hearing recovered to nearly normal, and it can persist for more than 6 months. So based on these promising findings, several companies are very serious to start the gene therapy for auto mutation. So as you may already know, that two Boston companies, that is the Yakuos and the Decibel Therapeutics, they have already obtained FDA clearance in this September for gene therapy for auto. So as one of the clinical trial sites, actually we are also planning our first case in the next few months. So another entry point for gene therapy, of course, is related to syndromic hearing loss. And as you may already know, that there is already FDA approved gene therapy for eye diseases. So another entry point is genetic etiologies related to poor CA outcomes, such as PJVK mutations. So over the past years, we also selected several genetic mutations which have been related to poor CA outcome, and we try to generate transgenic mouse models using CRISPR technique. Here you can see our data in our PJVK mice. You can see the mouse reveal circling behavior, and the hearing is progressive, severe to profound hearing loss, and you can see the degeneration of the hairs, and you can see the degeneration and the decreased cell density of the spiral ganglion neuron. So the degeneration of the spiral ganglion neuron might explain for the unfavorable, the poor outcome we observed in our CI patient. So recently, we tried to do gene therapy in PJVK mice using the ENC-AT vector. And as you can see on this slide, the ENC-AT showed a very good transduction efficiency in both the spiral ganglion neurons and the hair cells. And after gene therapy, the vestibular functions improve. You can see before gene therapy, there is circling behavior, but after gene therapy, the circling behavior disappeared, and the mouse can walk straight. So regarding the auditory function, there is only a partial improvement. The hearing improved from 100 decibel to about 80 decibel, but the morphologies improved more. Here you can see the morphology of hair cell improved, and I think more importantly is that the spiral ganglion neuron density maintained quite well after gene therapy. It's very close to the wild type. So this shows that maybe cochlear implantation plus gene therapy might be another solution for this patient with a genetic mutation related to poor CA outcome. So in our recent study, we are trying to develop cochlear as to deliver CI electrode with both mechanical and biological functions we try to design an electrode that can deliver drugs such as steroid, neurotrophic factors, or even gene therapy biovectors after the electrode is inserted into the cochlea. So let me conclude my talk today. Comprehensive genetic examination using NGS or the newly developed the long-read third generation sequencing significantly facilitate accurate diagnosis in childhood hearing impairment. Genetic information can help predict the outcomes and steer the treatment, such as cochlear implantation for childhood hearing impairment. Gene therapy for hereditary hearing impairment is around the corner and may start from auto-related, syndromic, SLC26F4 related, and poor CA outcome related hearing loss. So with that, I would like to thank my colleagues in Taiwan, especially my mentor, Professor Chen-Chi, and all the other colleagues in Taiwan. And thank you very much for your attention. Thank you.